So let's drill into this issue of why people with ADHD actually can focus very intensely on things that they enjoy and are curious about. Now, enjoyment and curiosity are psychological terms. They're not even really psychological terms. They're just the way that we describe our human experience of liking things, wanting to know more about them. But from a neurobiological perspective, they have a very clear identity and signature, and that's dopamine. Dopamine is released from neurons. It's what we call a neuromodulator. And as a neuromodulator, it changes the activity of the circuits in the brain such that certain circuits are more active than others. And in particular, dopamine creates a heightened state of focus. It tends to contract our visual world, and it tends to make us pay attention to things that are outside and beyond the confines of our skin. It's what we call exteroception. Dopamine also tends to put us in a state of motivation and wanting things outside the confines of our skin. So whether or not we're pursuing something physical in our world, or whether or not we're pursuing information in our outside world, dopamine is largely responsible for our ability and our drive to do that. But dopamine as a neuromodulator is also involved in changing the way that we perceive the world. So as I mentioned earlier, you have all these senses coming in, and you can only perceive some of them because you're only paying attention to some of them. Dopamine, when it's released in our brain, tends to turn on areas of our brain that narrow our visual focus and our auditory focus. So it creates a cone of auditory attention that's very narrow. It creates a tunnel of visual attention that's very narrow. Whereas when we have less dopamine, we tend to view the entire world. We tend to see the whole scene that we are in. We tend to hear everything all at once. So as I describe this, hopefully you're already starting to see and understand how having dopamine release can allow a person, whether or not they have ADHD or not, to direct their attention to particular things in their environment. Right? So now what we're doing is we're moving away from attention as this kind of vague, ambiguous term, and we're giving it a neurochemical identity, dopamine, and we are giving it a neural circuit identity. And just to put a little bit of flavor and detail on which neural circuits those are, I wanted to discuss two general types of neural circuits that dopamine tends to enhance. So let's talk neural circuits. And for those of you that love hearing neuroscience nomenclature, you're going to eat this part up. And for those of you that don't like a lot of names of brain areas, I invite you to tune out or just try and grab the top contour of this. I will describe it in pretty general terms, but I will give some detail because I know there are some of you out there who really want to dig deeper into what the exact structures and connectivities are. Okay? So there are two main types of circuits that we need to think about with respect to ADHD, attention and dopamine. The first one is called the default mode network. The default mode network is the network of brain areas in your brain, in my brain, and in everybody's brain that is active when we're not doing anything, when we're just sitting there idle at rest. Now, it's very hard to not think about anything, but when you're not engaged in any type of specific task, so you're not driving, you're not playing a video game, you're not trying to study, you're not trying to listen, you're just sitting there letting your brain kind of go wherever it wants to go, your default mode network underlies that state of mind. The other set of circuits that we're going to think about and talk about with respect to ADHD are the task networks. The networks of the brain that make you goal-oriented, or that are at least trying to make you goal-oriented. And those are a completely different set of brain areas. However, the default mode network and these task networks are communicating with one another, and they're doing that in very interesting ways. So first I want to describe how these two sets of brain areas, the default mode network and the task networks, normally interact. Okay? So a little bit of naming here. Again, feel free to ignore it if you don't want this level of detail, but the default mode network includes an area called the dorsolateral prefrontal cortex. Frontal cortex, no surprise, is in the front, and you have a dorsal, the top, and side, lateral part, dorsolateral prefrontal cortex. You got one on each side of your brain, right? And then you have a brain area called the posterior cingulate cortex. And then you have an area called the lateral parietal lobe. Again, you don't need to remember these names, but these are three brain areas that normally are synchronized in their activity. So when one of these areas is active in a typical person, the other areas would be active as well. So it's a little bit like a symphony or a band, like a three-piece band. It's like drums, guitar, and bass. They're playing together, okay? That's how it is in a typical person. In a person with ADHD, or even a person who has subclinical ADHD, or in any human being who hasn't slept well, what you find is the default mode network is not synchronized. These brain areas are just not playing well together. Now, the task networks include a different set of structures. It still involves the prefrontal cortex, but it's a different part of the prefrontal cortex. Okay, tends to be the medial prefrontal cortex. And there's some other brain areas that the medial prefrontal cortex is communicating to all the time, mainly to suppress impulses. It's shutting down the desire to stand up or to scratch the side of your cheek or your nose if you're trying not to do that. Anytime you're restricting your behavior, these task-directed networks are very active. Okay? Now, normally, in a person without ADHD, the task networks and the default mode networks are going in kind of seesaw fashion. They are actually what we call anti-correlated. So it's not just that they are not correlated, they are actually opposing one another. They are anti-correlated. In a person with ADHD, the default mode networks and the task networks are actually more coordinated. That might come as surprising. I think that we all have this tendency to kind of jump to conclusion and assume that somebody who doesn't have an easy time paying attention or has ADHD, that their brain must be completely incoherent, that it's not working well and because everything's out of whack. But there's something interesting about people with ADHD whereby the task networks and the default mode networks are actually working together in a way that's correlated, and that is what's abnormal. So this would be like the guitar, bass, and the drums playing together in a way where the bass isn't keeping the backbeat and the drums aren't keeping the backbeat, that they're playing together, they're all playing the melodies and harmonies in a way that just doesn't sound right. That's what's going on in the brain of somebody with ADHD. And we can now confidently say, based on brain imaging studies, that when somebody gets better when they're treated for ADHD or when they age out of ADHD, as sometimes is the case, that the default mode networks and the task networks tend to become anti-correlated again. Okay? So that's the underlying neurobiology, but you'll notice that I didn't mention dopamine at all. What dopamine is doing in this context is dopamine is acting like a conductor. Dopamine is saying this circuit should be active, then that circuit should be active. It should be default mode network, and then when the default mode network is not active, then it should be the task network. So it's really acting as a conductor saying, you go, now you go, now you go, now you go. And in ADHD, there's something about the dopamine system that is not allowing it to conduct these networks and make sure that they stay what, the engineers or physicists or mathematicians would say out of phase, to be anti-correlated. Okay, out of phase and anti-correlate, essentially the same thing, at least for purposes of this discussion. So that raises two questions. Could it be that dopamine is not at sufficiently high levels? Or could it be that dopamine is just doing it all wrong? In other words, is there no conductor, or is the conductor playing with like little tiny toothpicks, and so the instruments can't see what they're supposed to do? They can't get the instruction because it's just not loud enough, so to speak. Or could it be that the information is getting out, but the information that's getting out is wrong? The conductor is there, but the conductor isn't very good at conducting. Now, we can gain insight into how this system works and fails, and how to treat it, by looking at some of the current and previous treatments for ADHD, as well as some of the recreational drugs that people with ADHD tend to pursue and like. Now, I'm certainly not a proponent of people with ADHD taking drugs recreationally. That's not what this is about. But if you look at their drug-seeking behavior and you couple that drug-seeking behavior to their desire to remedy their attention deficit, you start gaining some really interesting insight into how dopamine is regulating these circuits in normal circumstances and in people with ADHD. So what exactly is going on with the dopamine system in people with ADHD? And what's going on with the dopamine system in people that have terrific levels of attention for any task? Well, in the year 2015, an important paper came out. The first author is Spencer, and it came out in a journal called Biological Psychiatry. And it formalized the so-called low dopamine hypothesis of ADHD. The idea that dopamine was somehow involved or not at the appropriate levels in people with ADHD had been around for a pretty long time. But a formal proposition of the low dopamine hypothesis led to some really important experiments and understanding of what goes wrong in ADHD. It turns out that if dopamine levels are too low in particular circuits in the brain, that it leads to unnecessary firing of neurons in the brain that are unrelated to the task that one is trying to do and that is unrelated to the information that one is trying to focus on. So if you think back before, you've got this default mode network and a task-related network, and they need to be in this kind of concert of anti-correlation, and in ADHD, they're firing together. Well, the problem seems to be that when dopamine is low, certain neurons are firing when they shouldn't be. This is like a band, right? We'll go back to our band. That's a guitar, a bass, and a person playing the drums. And it's as if one of those or several of those instruments are playing notes when they shouldn't be playing, right? The pauses in music are just as important as the actual playing of notes. When dopamine is too low, neurons fire more than they should in these networks that govern attention. This is the so-called low dopamine hypothesis. And if you start looking anecdotally at what people with ADHD have done for decades, not just recently since the low dopamine hypothesis has been proposed, but what they were doing in the 1950s and in the 1940s and the 1960s, what you find is that they tend to use recreational drugs, or they tend to indulge in non-drug stimulants. So things like drinking 6 cups of coffee, or quadruple espressos, or when it was more prominent, smoking a half a pack of cigarettes and drinking 4 cups of coffee a day. Or if the person had access to it, using cocaine as a recreational drug, or amphetamine as a recreational drug. All of those substances that I just described, in particular cocaine and amphetamine, but also coffee and cigarettes, increase levels of multiple neurotransmitters, but all have the quality of increasing levels of dopamine in the brain, and in particular, in the regions of the brain that regulate attention and these task-related and default mode networks. Okay? Now, young children, fortunately, don't have access to those kinds of stimulants most of the time, and those stimulants all have high potential for abuse in adults. So we will talk about the potential for abuse in a few minutes. But if you look at children, even very young children with ADHD, they show things like preference for sugary foods, which also act as dopamine-inducing stimulants. Now, of course, once they get access to soda pop and coffee and tea, they start to indulge in those more than other people. For a long time, it was thought that children with ADHD consumed too many sugary foods or drank too much soda, or adults with ADHD would take recreational drugs like methamphetamine or cocaine, or would drink coffee to excess or smoke cigarettes to excess because they had poor levels of attention and because they couldn't make good decisions. They were too impulsive and so forth. And while that certainly could be the case, knowing what we now know about dopamine and the fact that having enough dopamine is required in order to coordinate these neural circuits that allow for focus and quality decision making, an equally valid idea is that these children and these adults are actually trying to self-medicate by pursuing these compounds. Right? Things like cocaine lead to huge increases in dopamine. Well, what happens when somebody with ADHD takes that drug? It turns out they actually obtain heightened levels of focus. Their ability to focus on things other than things they absolutely care intensely about goes up. Likewise, children who consume anything that increases their levels of dopamine, if those children have ADHD, they tend to be calmer. They tend to be able to focus more. Now, this is very different than children who do not have ADHD. When they consume too much sugar, they tend to become super hyperactive. When they consume any kind of stimulant, they tend to go wild and run around like crazy. I actually have an anecdote about this just to illustrate it. I have a friend. He has 2 children that are now in their teens and 20s, but when they were little, one time I brought them some chocolate just as a gift when I showed up at their house. And within 30 minutes, the kids were running around like crazy. I mean, they were pretty high energy kids, but they were going bonkers. And that's actually when the mother, my friend at the time, unfortunately still now, looked at the chocolate and realized that it was chocolate with espresso beans in it. It was like dark chocolate espresso beans. So I was really at fault there. You don't want to give kids dark chocolate with espresso beans, but what you're really seeing, that hyperactivity, that is dopamine, okay? It's the sugar combined with the caffeine, in this case, combined with a few other compounds that exist in chocolate that really increase our levels of alertness and our tendency to want to move around a lot. Okay, so dopamine and low levels of dopamine apparently are what's wrong in people with ADHD. That dopamine hypothesis is what led to the idea that treating people, children and adults included, with dopaminergic compounds would somehow increase their ability to focus. And if you look at the major drugs that were developed and now marketed by pharmaceutical companies for the treatment of ADHD, those drugs have names like Ritalin. Nowadays, it's typically things like Adderall, modafinil, and some of the other derivatives. They all serve to increase levels of dopamine, in particular dopamine in the networks that control task-directed behavior and that coordinate the default mode network and these task-related networks. So many of you have probably heard of Ritalin. Ritalin is a prescription stimulant that is prescribed for ADHD as well as for narcolepsy. Narcolepsy is a condition in which people tend to fall asleep during the daytime quite a lot. It's excessive daytime sleepiness, not due to lack of sleep at night, but also tend to fall asleep when they get excited. If they're really emotionally excited or about to eat or any other kind of activity that would normally get somebody really aroused and alert, people with narcolepsy tend to fall asleep, or they tend to become what's called cataplectic. They tend to just sort of go limp in the muscles. So it's this invasion of sleep into the daytime. It's dysregulated by emotion. You can imagine why a stimulant, something that would wake you up, make you very alert, focused, and motivated, would be a good treatment for narcolepsy. Adderall also is used to treat ADHD and to treat narcolepsy. Things like modafinil, also used to treat ADHD and narcolepsy. So you're sensing a theme here. So what are the differences and similarities between these drugs, and what can that tell us about ADHD? Well, Ritalin was one of the first generation drugs that was prescribed for ADHD in order to deal head on with this dopamine hypothesis, this idea that in ADHD, dopamine levels are too low. Nowadays, Adderall is the more typically prescribed drug for ADHD. That has to do with some of the so-called pharmacokinetics, the rate at which those drugs enter the system and how long they last in the system. So, for instance, Ritalin was a drug that was packaged into various time-release formulas, whereas initially Adderall was only released in a form that had a very short life, so meaning that it wasn't in the bloodstream very long and didn't affect the brain for very long, and so the dosages could be controlled in a more typical way. Without going into a lot of tangential detail, as you all know, at different times of day, you tend to be more or less alert. So a long, sustained release drug, while that might sound like a really terrific thing, if that drug is having an effect of making you more alert and it's released across very many hours of your day, there might be periods of your day when you feel too alert, periods of your day when you feel just right, and periods of your day when you wished that you were more alert. These are some of the pharmacokinetics, kinetics meaning movement, of the different compounds within the bloodstream and brain that you could imagine in a very real way would impact whether or not someone would feel really good on one of these drugs or whether or not they would feel too anxious or too sleepy and so on. Let's take a step back for a second and just ask, what are these drugs? We know they increase dopamine, but what are they really? Well, Ritalin, also called methylphenidate, is very similar to amphetamine, speed, or what's typically called speed in the street drug nomenclature. Adderall, which goes by various other names, okay, so Adderall, Adderall XR, Midasis, things like that. Adderall is basically a combination of amphetamine and dextroamphetamine. Now, some of you probably realize this, that Adderall is amphetamine, but I'm guessing that there are a good number of you out there, perhaps even parents and kids, that don't realize that these drugs like cocaine and amphetamine, methamphetamine, which are incredibly dangerous and incredibly habit-forming and have high potential for abuse, well, the pharmaceutical versions of those are exactly what are used to treat ADHD. Now, they're not exactly like cocaine or methamphetamine, but they are structurally and chemically very similar, and their net effect in the brain and body is essentially the same, which is to increase dopamine primarily, but also to increase levels of a neuromodulator called epinephrine or norepinephrine, also called noradrenaline and adrenaline. Those names are the same. And to some extent to increase levels of serotonin in the brain and blood, but not so much serotonin. That's just kind of a small smidgen of effect. Okay, so dopamine way up, norepinephrine and adrenaline way up. So that's motivation, drive, focus, and energy. And to some extent, a little bit of serotonin, which is really more about feeling calm and relaxed. And you can imagine why that would be a good balancing effect for dopamine and norepinephrine. So what I'm essentially saying is that the drugs that are used to treat ADHD are stimulants, and they look very much like, in fact, nearly identical to some of the so-called street drug stimulants that we all hear are so terrible. However, I do want to emphasize that at the appropriate dosages and working with a quality psychiatrist or neurologist or family physician, it does have to be a board certified MD that prescribes these things, many people with ADHD achieve excellent relief with these drugs. Not all of them, but many of them do, especially if these treatments are started early in life. So now, knowing what these drugs are, I want to raise the question of why prescribe these drugs? I mean, everyone has to make a decision for themselves or for their child as to whether or not they're going to take these things or not. I also want to acknowledge that many people out there, many people out there, are taking these drugs even though they have not been clinically diagnosed with ADHD. And when I say these drugs, I'm specifically referring to Ritalin and Adderall and modafinil, but more typically it's Adderall. Okay? People using cocaine and amphetamine for recreational purposes, that's a completely different beast, and it is indeed a beast, and it's something that I strongly discourage. However, I am aware that up to 25% of college students, and perhaps as many as 35% of all individuals between the ages of 17 and 30 are taking Adderall on a regular or semi-regular basis in order to work, in order to study, and in order to function and focus in their daily life, even though they have not been diagnosed with ADHD. There's a whole black market for this. They're getting it from people with prescriptions. I'm not here to pass judgment. I just want to emphasize how these drugs work, some of the things that they do to enhance cognition and focus that actually serve the brain well in certain individuals, and how they can be very detrimental in other individuals. I sort of blew right past it, but the fact that in upwards of 25% of young people are taking things like Adderall despite not having a clinical diagnosis of ADHD, well, that's a ridiculously high number. A few years ago, it was estimated that Adderall use and Ritalin use without diagnosis of ADHD was second in incident only to cannabis. But actually now, the consumption of Adderall without prescription is higher than the consumption of cannabis in that age group. So what that means is that there's a lot of stimulant use in that age group. And there are a lot of adults also using and abusing stimulants in order to gain focus. Now, we could have a whole discussion about whether or not life is becoming more demanding, whether or not the need for focus is excessive, and that's why people are doing that. Frankly, it's an interesting discussion, but it's not one that would deliver us to any answers. Rather, I'd like to focus on the ways that people now and people have always been self-medicating to increase focus, right? Caffeine, which I indulge some, I don't think to excess, has long been used as a stimulant to increase dopamine, increase norepinephrine, increase focus and energy. And in addition to that, it works through the so-called cyclic AMP phosphodiesterase pathway. Remember, anytime you hear an ASE, that's an enzyme. Phosphodiesterase is involved in the conversion of things like cyclic AMP into energy for cells and so forth. Basically, coffee gives you energy. It makes you feel good. And it increases focus because of the circuits that it engages in the brain. People have been taking caffeine and continue to take caffeine for ages. People also used to smoke cigarettes, nicotine, in order to gain focus. Nowadays, that's less common because of the concerns, quite valid concerns, about lung cancer from smoking. But there's a lot of vaping out there. There are a lot of people now consuming nicotine, which is the active substance in cigarettes and in most nicotine vapes that stimulates the brain to be more focused and more alert. So the idea of taking stimulants, of consuming things or smoking things in order to increase alertness is not a new idea. It's just that in ADHD, it's surprising that these things would work, right? I mean, if the problem is attention deficit hyperactivity disorder, what we're really talking about here are children that are prescribed a drug that ought to be a stimulant. It ought to make them hyperactive. And rather than doing that, it actually somehow serves to calm them a bit or at least allow them to focus. Here's the reason. Children have a brain that's very plastic, meaning it can remodel itself and change in response to experience very, very quickly compared to adults. Taking stimulants as a child, if you are a child diagnosed with ADHD, allows that forebrain task-related network to come online, to be active at the appropriate times. And because those children are young, it allows those children to learn what focus is and to sort of follow or enter that tunnel of focus. Now, by taking a drug, it's creating focus artificially. It's not creating focus because they're super interested in something. It's chemically inducing a state of focus. And let's face it, a lot of childhood and school and becoming a functional adult is about learning how to focus even though you don't want to do something. In fact, when I was in college, I had this little trick that may or may not work for some of you, which is if I couldn't focus on the material I was trying to learn, I would delude myself into thinking that it was the most interesting thing in the world. I would just kind of lie to myself and tell myself, okay, this, I won't mention the subjects. I absolutely love this. I would tell myself that I loved it. And I noticed that just that selective or deliberate engagement of that desire to know circuit, whatever that is in my brain, no doubt it involves dopamine, allowed me to focus and remember the information. And somewhat surprisingly, or perhaps not surprisingly, I would often fall in love with the information. I'd find that was my favorite class. It was what I wanted to learn the most. So that's one way you can do it artificially, but kids with ADHD, they can't do that, right? They're told to sit still and they end up getting up 11 times. They are told that they can't speak out in class or that they have to remain in their seats for 10 minutes and they just, despite their best effort, they simply cannot do it. They're highly distractible. So what are we to make of this whole picture that we need more dopamine, but these kids with ADHD, they're getting their dopamine by way of a drug, which is, for all the world, amphetamines, right? It's speed. That's really what it is. What are the long-term consequences? What are the short-term consequences? And what should we make of people taking these drugs without a clinical need? What are the consequences there? Well, in order to get to some of those answers, I went to one of my colleagues. This is a colleague that I've actually known for a very long time. I was their teaching assistant when they were an undergraduate. They went on to get an MD, a medical degree, as well as a PhD, and have become a pediatric neurologist that specializes in the treatment of epilepsy and ADHD in kids of all ages, from age 3 to 21. That's the age range, pretty broad age range, and has extensive knowledge in this. And what makes them particularly interesting for sake of this discussion is that they have a child, a young boy, who's now showing signs of ADHD, and they are on the threshold of trying to decide whether or not they will prescribe Adderall or something similar. So we had a discussion about this, and prior to learning that their child may have ADHD, I asked the following questions. First of all, I asked, what do you think about giving young kids amphetamine? And their answer was, on the face of it, it seems crazy, but provided that the lowest possible dose is used and that dosage is modulated as they grow older and develop those powers of attention, their observation was that they've seen more kids benefit than not benefit from that. Now, I'm certainly not saying what people should do. You obviously have to go to a doctor because, as I always say, I'm not a doctor. I don't prescribe anything. I'm a professor, so I profess things. And here I'm professing that you talk to your doctor if you're considering giving Ritalin or Adderall or any type of stimulant to your child, of course. What could be more important than the health of your child? But it was a very interesting answer because typically we hear, yes, medicate or don't medicate. Rarely do we hear that the medication should be adjusted across the lifespan and in any particular kind of way. Now, the fact that this person, this now friend of mine and colleague of mine, has so much expertise in the way that the brain works and is considering putting their child on such medication. I said, why wouldn't you wait until your kid reaches puberty? I mean, we know that in boys and in girls, there are increases in testosterone and estrogen during puberty that dramatically change the way that the body appears, but also that dramatically change the way that the brain functions. In particular, we know this, that puberty triggers the activation of so-called frontotemporal task-related executive functioning. That's just fancy science speak for being able to focus, being able to direct your attention, being able to control your impulses. Look at a small child, or look at a puppy, and then look at an older child, or look at a dog. Very different levels, patterns of spontaneous behavior. Young children move around a lot. They're I don't want to say shifty, because that makes it sound like they're up to something bad, which they might be, but they don't have to be up to something bad. They fidget a lot. So do puppies. Everything's a stimulus. As animals and humans get older, they learn how to control their behavior and sit still, listen, and focus, even if they don't want to. So giving a drug that allows a child to access that stillness early on, it's thought will allow them to maintain that ability as time goes on. But I decided to push a little bit further. I said, well, why would you do it now as opposed to during puberty or after puberty? And their answer was very specific and I think very important. What they said was, look, neuroplasticity is greatest in childhood and tapers off after about age 25. But neuroplasticity from age 3 until age 12 or 13 is exceedingly high. And they're right. When you sit back and you look at the literature on neuroplasticity, you'd say childhood plasticity and young adult plasticity is much greater than adult plasticity, but that early childhood plasticity is far and away the period in which you can reshape the brain at an accelerated rate. So this lines up really well with the clinical literature. Not surprisingly, they're a clinician, that early treatment is key. If you have the opportunity to work with a quality physician and treat these things early, these drugs can allow these frontal circuits, these task-related circuits, to achieve their appropriate levels of functioning and for kids to learn how to focus in a variety of different contexts.